Hi, this is Brian Kim. I'm going to share with you case number 273 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so you can constantly refine and hone your technique so that you can provide the very best for your patient. And so you're going to see very quickly in this case, I'm going to go straight to the phaco, but I'm going to do capsulorhexis. You're going to see immediately this patient has severe zonulopathy, and I'm not going to be able to salvage this bag. But I want to highlight some key steps in how I'm able to detect that there's bad zonules and how I'm going to take this lens out. So you can see here, I've already made my incisions. I put viscoelastic in the eye, and I'm puncturing with my sharp rhexis forceps. You can see the stria, the radial stria lines, as I'm puncturing and pushing down on the capsule. That is a sign of zonulopathy. I begin to do my rhexis, and I'm kind of out of view as I do this, and unfortunately I didn't recenter. But as I'm pulling, I can see the entire bag is moving as I'm trying to do the rhexis. So I'm pulling with my forceps to move the flap along, and as I do that, I can see the whole bag moving. And of course, I'm going very slowly, but I can see that the zonules are going to be really, really bad. And, I'm just thinking outside, I might be able to put a CTR in, save the bag, put a 3-piece lens or something like that. But in my mind, I'm also thinking maybe it's not going to go the way I plan. And so you have to be thinking about all these things as you're simultaneously doing the procedure. Burping some viscoelastic out, placing some viscoelastic on the cornea so that I can see better. And this is the hydrodissection technique, capsule fornix. As I try to place the capsule fornix cannula out, you can see the lens is wobbling quite a bit. So you saw me had to go kind of back and forth. And then I'm not too aggressive filling the capsular bag with the BSS because I know that I can't decompress well because the zonules are so weak. So I was very gentle with hydrodissection. So again, you're thinking about all of these things way ahead of time, even before I get started with phaco. So watch this. As I try to remove some of the surface material, look at the lens jump. When the lens jumps like that, that tells you the zonules are a little bit weak. And so I go straight to sculpt. And as I go straight to sculpt, again, you see the lens jumping up towards me. Again, not a good sign. And I'm sculpting. And again, mind you, this says Centurion on the display, but this is actually the J&J Veritas machine. So I'm using the Veritas. I do a little bit of sculpt, and this is the terminal chop technique, placing the chopper out to the equator, fracturing the lens from the contralateral side, which works very well. This is a cross chop, placing the chopper around the right heminucleus, hooking the peripheral lens, and then placing the phaco-tip deep and fracturing the right heminucleus in half. So I'm trying to grab that first quadrant up, and as I do that, I'm eating the piece. And as I eat the piece, look at the bag. The bag just kind of just wobbling and jiggling around, and that's kind of a bad sign. That is a sign that this lens is very, very unstable. So let's look at this in half speed. You can see as I'm eating that first quadrant, the lens and the whole bag is just wobbling. So again, you have to really pay attention to the details as you're doing these cases. So I'm going to go ahead and crack some more, and then I'm going to go after that second quadrant, performing another cross chop, placing the phaco-tip deep, trying to get the chopper around the lens. And utilizing mechanical fracturing is really essential and advantageous in these cases. Whenever the bag is unstable, you never want to go after the lens pieces with high vacuum. When you do that, you're going to eat the bag and you're going to damage more zonules. So you can see here, as I'm trying to place the chopper out, look at how much the whole lens bag complex is wobbling. So I'm very careful here. You see how much it's wobbling? I'm having a hard time grabbing that last piece, and that's on that right side. And I don't want to yank it because it's still attached to the bag, the lens piece. So I'm going after the left side. So you see here, I'm using vacuum to grab the endonucleus. But then look here, I'm going to use the chopper to tease the endonucleus off the rest of the lens and the capsular bag. So I'm using that chopper to physically peel and separate the lens off the bag. You can see I did that right now. And now I'm able to use vacuum to lift that endonucleus up. Again, I use that chopper and vacuum on the phaco-tip to physically tease and separate the lens from the bag complex. And using that chopper, I was able to gently just push that bag back And so I didn't cause any zonular stress. And once I was able to separate the endonucleus from the rest of the lens bag complex, I was able to just go ahead and eat that left half heminucleus. So now there's this last quadrant piece. Again, I'm trying to bring it towards me with the chopper, and it's not coming. You can see that's attached to the bag still. I'm pulling, using the chopper, pulling the lens piece to the center, and it's just not coming off. So what am I going to do? I'm going to use a BSS cannula to rehydrodissect that lens up. I'm trying to get a fluid wave. Again, I'm getting underneath the rexus edge on top of that lens piece. I'm pushing BSS, trying to do another hydrodissection to physically separate that lens piece from the bag. You can see here the lens actually kind of spun more subincisional now. I'm trying to, again, use the chopper to gently tease the lens piece up. So now I'm retracting the rexus with the chopper and using vacuum to try to pull that lens piece up, and now it comes up. And so that's that last endonuclear piece, using vacuum to pull it up, using the chopper to protect and shield the anterior capsule, the capsular rexus subincisionally. And then now I'm eating up that last quadrant. So now all the endonucleus is out. There's a little fragment there. Go ahead and eat the epinucleus. It's very important to make sure that the epinucleus is disassociated from the bag here, because if it's not, you're going to be eating the bag and then ripping more zonules. So it's very careful to watch that. Fortunately, the epinucleus was disassociated from the bag. So I take the chopper out, push BSS in, and then carefully take the phaco tip out. I go in with the INA handpiece, and immediately I can tell the bag is extremely unstable. It's wobbling severely, and as I'm grabbing the cortex, you can see the whole bag is moving. You saw that sudden jerk of the bag. When you have that, that's because there's sudden pressure differentials as the fluid is turning on and off, and that sudden pressure differential is going from like 0 to like really high pressure, 50. You can see the bag just jerking. And when that happens, that's a sign of zonulopathy. So I'm pushing BSS, and as I do this, you can see the bag jerking, and I'm not really taking a chance. Go ahead and close my main incision with a 10-0 nylon suture, and then we're switching to the Yamane. So again, I don't do Yamane from a temporal incision. I do it supratemporally. So this is a left eye. I'm making my mark supranasal on the limbus with this 27 gauge cannula. I like to ink the tip. You get a really nice discrete mark. I mark it on the right side and then the left side 180 degrees apart. This is a fixed caliper from Epsilon. I don't have any financial interests. I indent 2.5 millimeters posterior to that limbal mark and then 2 millimeters adjacent in a backwards L configuration on the right side. And then again, inking those indentations, doing the same thing on the left side, indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent with that fixed caliper in a backward 7 configuration on the left side, and then inking those indentations with the 27 gauge cannula. Again, really small, precise, and discrete marks. This is the trocar. I'm indenting 3.5 millimeters posterior to the limbus, tunneling about the same amount, tunneling towards that indentation, and then entering, and hopefully I have a self-sealing incision. You can see the trocar cannula is sitting a little bit tilted, which hopefully will mean it's going to self-seal. This is my contralateral limbal incision to externalize a leading haptic through a passive docking technique using a 25 gauge cannula, filling the eye with dispersive viscoelastic, and then performing my supratemporal 3 millimeter incision. Again, I'm using the J&J Veritas machine throughout this entire case, including with the vitrectomy. Bending the 25 gauge needle with the bevel facing to the right. This is my 22 gauge thin-walled AC maintainer. This is the Emerald cartridge, pushing cohesive viscoelastic on the platform. Placing the Sensor AR40 lens onto the platform, pushing the optic down, seating it down, bringing the wings together, making sure the optic goes backward, concave, The leading haptic goes through the barrel straight and the trailing haptic comes out through the back. Go ahead and place the cartridge into the emerald injector, making sure the trailing haptic is out and above the barrel so it doesn't get damaged. Placing the 25 gauge cannula through the contralateral nimble incision, having both bevels, the needle and the injector bevel, facing each other. My assistant is advancing the lens, and then I am docking the haptic on the bevel of the needle. As she advances the lens, more of the haptic goes into the needle. I withdraw the needle, the haptic comes out. I take over, make sure the optic comes out correctly, and then sweeping the trailing haptic to the right, trying to make sure the AC maintainer is above the optic. In this case, and in most cases, it would be nice to have infusion posterior, but I've never really gone that route. So you see here, I'm trying to push down on the AC maintainer. I'm pushing down on the outside so the inside part of the AC maintainer goes up, so I can kind of push the optic underneath it. I'm performing pars plana vitrectomy, anterior vitrectomy, just to make sure there's no vitreous underneath the bag. As you'll notice, I did not take the bag out. I'm just wanting to keep that bag there, acting as a shield for any vitreous. Pushing more dispersive viscoelastic to expand chamber, protect the cornea. I'm going to hold the trocar with 0.12 forceps. And then I'm going to stab at the first mark, which is again 2.5 millimeters posterior to the limbus, stabbing the congens sclera, staying nice and flat, tunneling through the scleral tissue. You can feel the resistance, and I'm using that 1-2 forceps as counterforce so I can feel that resistance. And when I get to the second mark, I dive down. You can see here now, because of the capsular bag is in the way, I'm using the forceps to help me kind of push the needle through the capsular bag material. And again, because of the AC maintainer, it's kind of pointed down. It's kind of snagging the edge of the optics. You can see here I'm trying to manipulate it so that it's clearing the AC maintainer. Again, having posterior infusion would bypass the need of having an AC maintainer, or potentially positioning the AC maintainer in a way where it's not in the way of my manipulation. Nonetheless, I went ahead and continued to perseverate. But you can see externalizing the leading haptic just gives me a lot more easy access to the trailing haptic with my technique. And once I feel comfortable with that, go ahead and work on the trailing haptic. I use a smooth microforceps from MST. Again, I don't have any financial interests. Grabbing the haptic. Making sure I have good exposure. Sliding the haptic, you can see I slid the haptic sideways. I don't just shove it, because you're going to bend the haptic and damage the haptic. So I do that sideways, sweeping to the left, and allow that haptic to just slide right in. And here, because of that lens material, it's kind of coming up. It's because of the fluid coming out of the wound here. The capsular bag material is kind of coming up, and my view is a little bit obscured. But I'm just taking my time. I'm very confident in what I'm doing. And so I'm just taking my time, making sure that I align the needle to the haptic. I have a good view here. I can see where it is. I have a good view. Go ahead and dock it. And you can see I did a couple of pushes. I did actually more pushes than I needed to. I did like 3 pushes. Disengaging the needle from the syringe. Internalizing the leading haptic and then laying it into the angle. You can see this bag is completely worthless. You can see, and again, it was like that before. It wasn't because of what I did. And again, all of this started from when I noticed when I punctured the capsule with a Rexus. That's what started all of my suspicion, and I was right. Contralateral fixation with the Calibri forceps, tunneling from the first mark, puncturing through the conjunctiva and sclera, stabbing it, and then flattening out, staying near parallel, feeling the resistance of the needle going through the sclera. Again, because I have contralateral fixation, I can feel the resistance getting to the second mark and then diving down. And then using these smooth microforceps carefully getting close to the tip, docking the haptic on the bevel needle, 2 pushes, and then I'm in. So 2 pushes is all you need because, again, this needle, the 30 gauge thin wall needle, grips the Sensor AR40 haptic so well. You don't have to feed so much haptic into the needle. Cauterize the tip. You get a beautiful little flange. Do the same thing on the other side. Again, you want to limit how much haptic comes out. So as I'm pulling the needle out, I'm using the forceps to kind of push the haptic back into the eye because I don't want so much of that haptic to stick out. By limiting how much haptic comes out, you limit how much stress is on the optic-haptic junction. You can see a nice flat approach of my haptics. The fact that the haptics are nice and flat, which means I have a nice scleral support, which means the lens is going to have excellent lens position, appropriate lens position. This is anterior vitrectomy to remove the bag material. You can see some of the bag prolapsed above the optic, so I have to go through a limbal incision to remove some of that capsular bag material anteriorly as well as behind it. This is my surgical PI using the Veritas J&J vitrector, and using a low flow setting, I'm able to achieve a really beautiful small PI. Again, don't go too peripheral. If you go too peripheral, you're going to get significant cerebral body bleeding and vitreous hemorrhage. It's just, I've learned through my own cases that that's just not necessary. Place another incision, a tendonolon suture, inflate the eye, and then massage, take the trocar out, massage the incision. You can see it, thankfully it's self-sealing. And then I'm using the vitrector to do cortical removal. So this is purely just vacuum to remove the viscoelastic in the anterior chamber. And then I'll use some BSS and a cannula to kind of pulse to create some turbulence to release some of that dispersive viscoelastic stuck to the cornea. And so this is the end of the case. So again, this is a case that was a zonulopathy case. Again, I wasn't really aware that this patient had zonulopathy. As I punctured the capsule, I saw the stria, the radial stria, the spider sign, which I call it. As I was pulling the rhexis flap, I could see that the whole lens was pulling towards me, which signifies that the zonules are fairly weak. As I was trying to initiate high vacuum with bevel down to remove the lens, I can see the whole lens wobbling. So again, all signs that are pointing to zonulopathy. So I did some sculpting to create some space and then perform terminal chop and then cross chop. Again, very carefully trying to separate the endonucleus from the rest of the lens bag complex using mechanical fracturing forces to do that. Remember, I couldn't pull that second quadrant up all the way, so I worked on the left heminucleus using vacuum to grab the lens, but then using my chopper to separate and peel and separate the endonucleus from the rest of the lens bag complex. Very nice technique to do that, again, using mechanical forces. Crushing the lens and then using hydrodissection again to get that second quadrant, loosening it, and I was able to get that piece out. So once the endonucleus was out, again, the bag, the cortex was just firmly adherent to the bag. I knew that if I went after that cortex, the whole bag would start to rip. The zonules would just kind of come out. So I performed my Yamane technique using the 25 gauge needle passive docking technique. Again, passively externalizing the leading haptic through a contralateral limbal incision. This allows me just much easier access to the trailing haptic. I start off with the right side needle. Again, I stab and I tunnel through the sclera 2 millimeters, and you really need to have good scleral support. Those of you who are not familiar with Yamane, you really need to make sure you're nice and flat, feeling the resistance, applying counterforce with forceps, pushing through the scleral tissue as you dive down 2 millimeters. You get nice scleral support, and then again, using that bevel concept, docking the haptic on the bevel of the needle. The 30 gauge thin walled needle holds these Sensor AR40 haptics so well. It grips it so well. Just a couple pushes is all you need. You saw once I externalize the haptic, again, minimizing how much haptic comes out, get a nice flat approach and no flagpole sign, which means this lens is going to be in great position. This patient ended up post-op day 1, 20/40 uncorrected vision. No corneal edema. Again, 20/40 uncorrected vision post-op day 1. and this patient did extremely well. So I hope this was helpful to you, and I thank you for your attention.